All right, everyone, we'll go ahead and get started on chapter 36. This is part two. It's the last part of Geriatric's Emergencies. So it'll cover some like assessment stuff and then some trauma and other miscellaneous stuff. And then we'll do the quick 10 question review at the end. So, for whatever reason, actually, I know why your book is obsessed with the Jim's Diamond. And, anyways, there's a whole class on this as well, like a card class you could take. But um, we'll just dive into it because uh, it's talked about a lot, and it can be helpful. So, basically, this GEMS diamond was created to help you remember what is different about older patients. It's not intended to be a format for the approach to geriatric patients or replace the ABCs of care, but it can serve as an acronym for the issues to be considered when assessing every old patient. Okay, and so the G is for geriatric patients. So older patients may present atypically. You should be familiar with the normal signs of aging, and so. On this thing out of the book, they deserve respect and they experience normal changes with age. And then so the E is more of environmental assessment. So the environment can help give us clues to the patient's condition and the cause of the emergency. So we'll just read some of these. And so, you'd want to check the physical condition of the home, check for hazards like poor wiring, rotted floors, cluster, area rugs. Area rugs are a very common cause of falls, so are pets. Is the home too hot or cold? Does it stink? Are the pets cared for? Is there liquor bottles? Are they empty? Does the patient have access to a telephone? Do they have running water? All these things that you would look for in an environment of an older person. Again, older people, I mean, everyone's on a fixed income, but older people especially may not be able to afford repairs and stuff like that have gone wrong with their house. And then, the M is for medical assessment. So, uh, they say, older patients tend to have a variety of medical problems and numerous medications. So you'd want to obtain a thorough medical history. And so, we could obtain a medical history, a full medical history, regardless of the chief complaint, your primary survey, your reassessment. Just be aware that also a trauma may have an underlying medical condition that could have been the cause or been made worse by this injury. And so the example would be like hypoglycemia caused them to fall, and so you get called for a fall, but it turns out they're hypoglycemic, or orthostatic hypotension caused them to fall and hit their head on the toilet, and now So basically, I mean, this could be for any age population, but especially geriatrics, that a medical cause could be a cause of their traumatic issue. And then the S for social assessment. Older people may have less of a social network, and so they may need assistance with what we've talked about. We call them ADLs or ADLs, activities of daily living. And so consider obtaining information, pamphlets about some of some of the programs in your area. And so, again, are they in the social assessment? Are they eating, bathing, toileting? Are they being well provided for? Are they wearing clothes? Do they have regular visits from family, church members? Do they live with someone? You know, do they have a social network? Is someone checking on them daily? And so you'd be surprised. There's patients that they've outlived all their family, and so they have no true family remaining. They just may have like a caregiver or someone from the church who comes by on Sundays and brings them food or something like that. Is not uncommon in the geriatric population. Okay. And so this is unfortunate to where you'll see people that live alone and don't have that social network. They fell, 3 days ago, and they've been on the floor the entire time because no one's came to check on them. And so, assessing an older person can be challenging because of the communication issues, the hearing and vision loss, alteration in consciousness, very complicated and very long medical histories, the effects of all the medications from the polypharmacy. And so, it kind of complicates it, but geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facility, also in public, of course, Walmart, stuff like that on the roadways. And so many older people live alone. Again, they've outlived their spouse or their kids or whatever, or their kids live by themselves and the parents live by themselves. So it's not uncommon. Um, uh, and access may be hampered if their condition prevents them from getting to the door. Had this happen a lot. You'll have old people fall in the middle of the night, going from the bed to the bathroom or something like that, but the house is locked up because it's the middle of the night, and so we have to end up breaking into their house to get to them because they can't get up. And so that's pretty common that you have to do stuff like that. In cases like that, you summon law enforcement and or the fire department to break into the home. And so take note of the negative or unsafe conditions and those. So those could be documented in your chart. And again, if you suspect like neglect or abuse or anything like that, you're obligated to report that to Adult Protective Services. So Adult Protective Services, like the CPS of Child Protective Services, there's APS, the Adult Protective Services, that investigate abuse of adults and neglect. And so, mechanism of injury, nature of illness. So it may be difficult to determine in older people with altered mental status or dementia, uh, like what the true cause is and what's going on because they're demented or they have an altered mental status. And so, a lot of times we'll lean on the family member or the caregiver. I've even had to use the neighbor or someone like that um, to be the historian of what's going on. Sometimes you don't have any of that, and you just have to use like the medications and whatever documentation or clues you can find around the house. Um, and so, this is really any patient, but whoops. Chest pain, shortness of breath, and altered level of consciousness should always be considered serious. Okay, cool. My Apple Pen's not going to work. All right. Um, and so address life threats, determine, our primary assessment is where we address life threats. You determine the transport priority. We form our general impression. Remember, our general impression is the impression that we form from across the room. We could use the AVPU, so they alert, or they respond to verbal stimulants, painful stimulus, or they just unresponsive to determine their level of consciousness. And so generally our across the room assessment, also known as our general impression that happens during our primary assessment, is where we determine if the patient's stable, unstable, sick, or not sick. And so remember, the anatomic changes that occur in older people predispose them to airway problems like choking, aspiration, respiratory fatigue, respiratory failure, all of those things. And so ensure that the patient's airway is open and not obstructed by dentures. If the dentures become detached, they could fall back and obviously choke on that. Vomit, blood, teeth, fluid, food, all of that. And so the anatomic changes affect the way the person breathes effectively. So remember, their muscles are not as strong, the diaphragm and the intercostals, that they would normally aid us in breathing. And so keep that in mind. Anatomic changes affect a person's ability to breathe. Um, Airway and breathing issues should be treated with oxygen as soon as possible. That's any patient. So poor perfusion is a serious issue in older adults. And so, that would be shock, right? Lack of perfusion is shock. And so the old person, their cardiac output's going to be decreased, especially if they're really old, because their heart is going to be weaker. Maybe it already has a degree of heart failure, and so the vascular changes and the circulatory compromise make it difficult to feel a pulse. And so it's not always easy to find the pulse on an older person. Okay, and so that's not as reliable. I always feel like I don't have a lot to add to these. Any transport that or any complaints that compromise the AVC should result in prompt transport, of course. Determine conditions that are life-threatening, treat them to the best of your ability, provide transport, right? And so you're going to investigate the chief complaint during your history taking. Okay, so obtain a thorough patient history. This can take a very long time because, again, they typically have a lot of medical issues and take a lot of medicines. Determine early whether the altered level of consciousness is acute or chronic. And so this is a good point that sometimes the altered LOC is chronic, so they're always kind of altered and have garbled speech and stuff like that. And so, if you don't have a historian, you don't have someone there to tell you, oh, they always talk like this. You could walk in and be like, oh my gosh, this is a stroke. And so it can be really difficult to assess these patients in that regard. And so just be aware that, when possible, if we have a historian or something like that, you would want to figure out like, oh, are they normally like this? Are they normally this confused? Are they normally slurring their speech like this? Are they normally tremoring like this? Whatever. So it can be difficult to distinguish the difference between something that's chronic and acute if you don't have a good historian, a good thorough medical history. And again, multiple disease processes and multiple vague complaints can make the assessment complicated. So where they'll tell you like, oh, my hands hurt, my stomach hurts, my back hurts, I'm nauseated. But I mean, they've had all of those same conditions for 10 years. And so it's like, whoa, what is really going on today can be really, really complicated to figure out and to try to assess. And so sometimes you'll have to kind of really dig into each of those. Okay, when did that start? Oh, 5 years ago. Okay, when this one start? Today. Okay, this one today. So what changed today? And so you have to really kind of dig into each of those complaints and figure out when they started, what aggravates them, OPQRST, all that stuff. So you'll collect a sample history. Again, you might have to rely on the caregiver or relative to help you with this. List the patient's medications. A lot of times I just take them with me to the hospital. The last meal is particularly important with patients with diabetes. Obviously, if they haven't eaten in 2 days or they just ate, can change things. Uh, and transport to a facility that knows the patient's medical history if possible. If you're a quarter mile from Texas Health Resources and a quarter mile from Baylor, and the patient's been going to Baylor their whole life, and all their doctors are at Baylor, and their last 3 hospital missions are at Baylor, take them to Baylor. That again, because all their history is in that system. Okay. Uh, Physical exam. Just keep in mind that older patients, much like any other patient, don't assume because they're old that they don't mind. That they don't want modesty. Every patient wants modesty. And so don't assume because someone's really old or really young that they don't want modesty. Everyone wants modesty. And so protect your modesty on the exam. Consider the need to keep your patient warm during the exam. Like I said, I make it rain blankets for old people. They love it. 5-star reviews when you give them blankets. And so this is an important point. The heart rate should be a normal adult range, but it may be compromised with medications known as beta blockers. Beta blockers are medications. Cool, my pen's really not working. Like metoprolol, labetalol, they end in LOL, carvedilol, propranolol. And so what these beta blockers do is they inhibit the heart rate. There we go. That works. Okay. And so the heart rate should be a normal adult range. But again, beta blockers, those are drugs that end in LOL, can block the heart rate from getting above 100. Okay. And so, these they could have weak or irregular pulses. So again, I've talked about what atrial fibrillation is. The heart will be irregular when that happens. And so that's not uncommon. Although it's not normal, it's not uncommon. And circulatory compromise may make it difficult to feel a radial pulse. Consider other pulse points like the carotids, the brachial, femoral, stuff like that. And so the blood pressure tends to be higher in older people. This is a known thing. It's chronic. Um, Capillary refill again can be compromised. Their skin is thinner. Their capillaries have changed. They're chronically cold. Their vessels have changed. So cap refill is a great tool. I would still use it. I would still document it, but it's not as reliable in older people. The respiratory rate should be the same as a young adult. Be sure to also take breath sounds and carefully assess pulse oximetry data. Now, pulse oximetry, again, they're always cold, so a lot of times what I have to do is I have to wrap their hand up in a blanket or put it under the blanket to keep it from getting cold and shunting blood away and not getting a good reading. So just like any patient, reassess these patients often, reassess their vital signs, reassess their complaint, recheck your intervention. Every intervention should be followed up by a check, right? Is it helping? Is it hurting? Is there no change? No change is fine, but we definitely don't want to do an intervention that is harmful and we're not catching it, okay? And so I don't have anything to add on that. Now, geriatric patient assessment guidelines, these are just some good general rules. When entering the home, take note of issues that would make it environmentally unsafe. You know, like I've had really soft floors. I've literally had a lady that had literally buckets of human waste, like poop. That happens. Introduce yourself, show respect, use patience to gain an older patient's confidence. So be confident, or be patient, be confident to gain their confidence and trust in you. Assessment of older patient can be complicated by multiple medical problems, the hearing problems, the vision issues. And so you just have to be patient, okay? Don't assume. Take your time. Be thorough. Be clear. Be precise. Be calculated with your movements and your words. Uh, Airway, breathing, circulation, and vital signs are changed by the normal process of aging. Many patients use multiple medications. We call that polypharmacy. Be aware of possible of overdose, underdose, and drug interactions. So, they're taking this drug that interacts with that drug, and so it makes this drug not work, or it works too much. That happens. Um, Older people are more easily affected by poor nutrition. Older people cannot thermoregulate and easily tend to be hot or cold. The memory and cognition of an older person may be impaired. The skin of an older person may be fragile and can tear easily. I'm going to show you what a skin tear is coming up. And so consider patient transfer options that are safe and appropriate. I'll show you what that means. And so trauma. So these are the conditions that create risk and complicate the assessment of a trauma patient, right? So they have slower homeostatic compensatory mechanisms. So remember, homeostasis is the balance of life. And so this balance is constantly working to keep us balanced and alive. But when you're older, again, like I've told you, everything's slower. And so that response to these changes in your environment and your life are slower. And so that could, you're slower to compensate. You have limited physiologic reserves. Again, most old people tend to be dehydrated. Even if they're not, they have less physiological reserve in the terms of fat, blood, volume, tissue. They're just less. Normal effects of aging on the body. Again, the effects of hypertension and arterial disease and all these issues that come along with all these effects of aging. And then they're going to have existing medical issues. Okay, and so that's going to complicate your trauma assessment, of course. Uh, So physical findings in an older adult may be more subtle and easily missed. So this is where you really do have to pay attention, because again, they could have a broken hip and they just say it hurts, right? I've had that happen. Their hip was literally broken and they were like walking somehow, and they were just kind of limping. And so again, they're it's just not as obvious sometimes with these older patients. And so the mechanisms of are much more minimal for like your physical exam. The recuperation from trauma is longer and often less successful. So what does that mean? Of course, if I broke my hip, I'm going to recover a lot faster than an 88-year-old lady. Okay. Many injuries are under triage and undertreated. Under triage meaning we don't take them serious, and then they're undertreated. We don't treat them as thorough as we should. And so older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. Again, this is intuitive. 88-year-old lady hit by a car versus me. The 88-year-old lady is not going to do very well. Okay. Be mindful of something called a secondary impact, and so that can cause serious injury. Older people are more likely to experience burns because of an altered mental status, inattention, or compromised neurological status. So again, they grab the hot pan off the stove, or they grab a hot pan of cookies out of the oven without a mitt on, or something like that. Or they get into too hot of bath water, or they fall and they knock the pan off the stove and it burns them, something like that. These are all things that are more common. Remember, a burn in an older person is a more critical burn. They have less fat, their skin is less healthy. Their vasculature is worse. It's not as robust. And so burns in older people are much more significant because they're less likely to heal, more likely to get infected, et cetera, et cetera. And so with burns, you have to worry about the infection, but their immune system's already weakened. One, two, you can't just load these patients up with like IV fluids because their kidneys can't support that. Usually their heart can't support that, and so you can end up with issues that way. So these are so intuitive. I mean, I feel odd reading these, but there's a higher mortality from penetrating trauma in older adults, especially gunshot wounds. Again, an 88-year-old lady gets shot in the gut versus a 29-year-old male. Who's going to do better? Now, this is an important thing. Falls are the leading cause of fatal and non-fatal injuries in older adults. I don't know what's up with gravity, but old people fall a lot, and so when they fall, um, they get injured, their bones are weaker, right? They have significant injury. And so sometimes this can be fatal. And again, if it's not fatal today, in the coming days or weeks, it very well could be fatal. Okay. And so, uh, nearly half of fatal falls in geriatric patients result in a traumatic brain injury. Okay. So a lot of times we'll talk about what this is. I'll just show you in a minute. And so anatomic changes to trauma. So, changes in the heart, the lungs, the brain, the musculoskeletal system make older people more susceptible to trauma. I've said this about 8 times. A geriatric patient's overall physical condition may lessen the body's ability to compensate for simple injuries. We've talked about that as well. We've talked about osteoporosis. This is brittle bone disease. It happens in older, thin women most commonly. It can happen in anyone though, and it predisposes them to hip and pelvic fractures. Okay, and so the contributing factors are stresses of ordinary activity, a standing fall, vitamin D and calcium deficiencies. This is because those Pac-Man guys in the bone will chew up the bone more likely or more aggressively when you're deficient on calcium and or vitamin D. Uh, Metabolic bone disease, this is more rare, but this would be like osteopenia or osteopetrosis. That's very rare. Tumors of the bone could result in a fracture of the bone, and we call that a pathological fracture when it relates to tumors. And so with age, I showed you this in the previous video. The spine stiffens, and as a result, there's a shrinkage of the disc, these little cartilaginous disc in between the vertebra. And so you do lose a little bit of height as we age for that reason. And so this is where you can get what I talked about earlier, the compression fracture, where if this is vertebra, these discs, instead of being nice and plump, they look like this, right? And so there's less cushioning, and so you can end up with a fracture in these vertebrae, and that's called a compression fracture. Who gets this? Older people who experience a fall. Most commonly, it's going to be someone with osteoporosis. In fact, a compression fracture of the spine and osteoporosis go together like, bread and butter. They go together. And so this is what I was talking about earlier. The brain shrinks when we age, and there's those bridging veins. And so when those bridging veins tear from a fall, you can get a subdural hematoma. And so this is a slow bleed that can take place over hours or even days. That can build up enough pressure to manifest symptoms. The symptoms typically present as stroke-like symptoms. So this is the lady that fell 4 days ago, and this morning she woke up with stroke-like symptoms because the pressure is built up enough in the head to create these stroke-like symptoms. And so this is why, again, getting a good history of like, oh, well, she fell 4 days ago in the shower and hit her head, but she thought she was fine. Well, that's an important detail to know. Okay. And so again, these head injuries are very serious in old people because of that whole bridging vein issue. Also because the fact they commonly take blood thinners, and if someone's on a blood thinner and they smack their head and they get a little bruise here, right, or a little bruise here even, if they're on blood thinners, it's going to bleed and bleed and bleed and bleed and bleed until they end up, having serious complications. And so we have to be very mindful of the older patient who's taking blood thinners of any kind and any type of trauma, especially head trauma. So I'll say that again. A patient who is old, who has hit their head, who is taking blood thinners, that is a level 1 trauma patient. That is a very, very sick patient. Even if they don't have major symptoms immediately, they need a very thorough workup. You have to worry about brain bleeding, a subdural hematoma. And so there's other factors that predispose an older patient to a serious head injury. So long-term abuse of alcohol will shrink the brain. It also thins the blood because it damages the liver, and clotting factors are made in the liver. Recurrent falls or repeated head injuries, that would be intuitive. If you smack your head 10 times a day, you're going to have more serious complications. And like I said earlier, anticoagulant medication, right? So those would be drugs like, you don't need to know the names today, but Eliquis, Xarelto, Pradaxa, warfarin, heparin, right? All those drugs that we give patients to thin their blood sometimes intentionally. We typically use this in cases of atrial fibrillation. Remember when the top of the heart's quivering? And so we'll give them these drugs. It's an injection or a pill that they'll take to help keep their blood thin to where it doesn't clot inside their heart and launch off and cause a stroke. I've talked a lot about environmental things, but this is an interesting thing to say. Half of all deaths from hypothermia occur in older people. Including most indoor hypothermia deaths. So again, older people may not be able to afford to heat their house, or their heater is broken and they can't afford to fix it or whatever. And so they can die in their own home even from hypothermia. So it doesn't have to be like literally freezing outside, but it's 40 degrees for a period of time, and they're in the house, and inside the house is 50 degrees. That's enough to kill an old person. Okay, so enough to kill a young person actually. And so just be aware of that. Death rates from hyperthermia, so high temperature, are more than doubled in older people. And so people older than 85 years of age are at a higher risk of death from hyperthermia, high body temperature. So isn't it? Because trauma is never isolated to a single issue when you're assessing and caring for a geriatric patient. And so, this is a good point that, if I were to fall and let me just say, if I were to kick the wall, right, and accidentally stub a toe, right, that's that. Maybe I just isolatedly stubbed my toe. And an old person, they kick the wall, they could very well stub their toe and now have vascular issues and swelling. They can lead to necrosis. They can lead to infection, right? So what they're trying to say is that, you know, it's not just the stub toe usually, right? It's the stub toe and all the consequences of having a stub toe in geriatric patients. And so it's just telling you keep an increased index of suspicion in young people and don't have tunnel, or I'm sorry, in old people and don't have a tunnel vision. Okay. So a lot of times we do have to, on our scene size up, look for clues. I tell you this all the time, you have to play detective, right? And so you have to look for what's going on. Like, you know, there's Meals on Wheels stacked up 4 days high on the porch. And so obviously they haven't been outside to pick up the Meals on Wheels for 4 days. So they've been in bed for 4 days. They've been laying in the ground. They've been sitting on the toilet for 4 days. So these are things like you have to use those clues like that to figure out how long, what's going on. Okay. Um, Bystander information is helpful. Even the nosy neighbor can sometimes be helpful if that's all you have. And so the mechanism of injury is important in establishing whether an injury is considered critical, and obviously that's going to affect your treatment and transport considerations. Okay, so during our primary assessment, you should have already addressed life threats, but determine the transport priority, right? Um, so remember, like an old lady that falls and hits her head taking blood thinners, that needs to go to trauma center. Uh, you'll learn that like in the field, but just general things like that you'll learn. And so uh, form a general impression. The patient stable, unstable, APU, GCS, stuff like that. I've already talked about that. Uh, Circulation, control external bleeding. Patients who are hypertensive prior to injury may have a normal pressure when they're actually going in shock. This is a very, 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 very important concept. Okay, so let's say grandma refuses to take her blood pressure medicine, and her blood pressure is normally 180 over 100. But today, when you get there, it's 120 over 80. But she's been having vomiting and diarrhea for 4 days. And you're like, oh, cool, she's normotensive, right? And so this is where blood pressure is not a great tool because it can be very deceptive. So keep that in mind that if someone's normally hypertensive and now they're normotensive or just slightly hypotensive, that could be it could be deceptive, and so just be aware of that. Um, it causes patients that are normally hypertensive that are now normotensive. They have dropped their blood pressure because they can't compensate where it was normally at, and so be aware of that. Uh, so consider, like I said, past medical events, even if they don't seem like they're acute or symptomatic, those are still things that we'll consider. Okay, so like, oh, you have a history of stroke, but today you're having chest pain, right? That's still significant that they've had a stroke, even though they don't have stroke symptoms right now. That means they obviously have vascular disease, right? They've been hospitalized before, and so just keep that in mind. So the physical exam, performed in the same manner as an adult with consideration of higher likelihood of damage from trauma. So again, we have a much elevated index of suspicion for geriatric trauma patients. You have to really worry about head injuries in geriatric patients. Again, for bleeding, for skull fractures, all the issues that come with that. So be very cognizant of a head injury in a geriatric patient. It is very serious until proven otherwise. So you'll assess the pulse, blood pressure, skin signs, right? Capillary refill, we've already covered this, is unreliable. But I just want to point out this is a skin tear. This is when the skin has literally torn. It's like paper thin. And so this creates this huge issue. So that's like, looks like it's on the arm. This looks like it's maybe on the knee or something. And so the skin can tear. And so you have to be very careful picking these patients up from the ground and stuff. Because if you pull them, like you can literally yank the skin off their hands or whatever you're grabbing. So be very, very careful yanking or pulling or tugging on a patient's skin when they're old like this. Even a blood pressure cuff can, tourniquet to start an IV or draw blood, that can tear their skin. And so, just be aware of that. Seatbelts, the stretcher can tear the skin. I don't have much to add on that. Um, so interventions do not force a patient with joint flexion or kyphosis into a normal position. And so you can have what's called contractures, right, to where the muscle or joint is locked into a position. You see this commonly in the hands. You can see it in any joint though, the elbows, knees, whatever, shoulder. And so if their shoulder has been locked up like this for 5 years or a year or a month or whatever, it's not your job to straighten that out. You're going to break their bone or break something. Okay. So if someone's locked into a position, we don't force it into what we would think would be a normal position. Okay. So that's an important concept. The other important concept is, if this is someone's head and their eyes are looking this way, right? So they're wearing a hat, it's going that way. They're looking that way. Okay. Um, this would be uh, kyphosis, right? So it's a hump in the back of the thoracic spine. It's like a hunched back. Okay, and so this is fairly common in older patients as we age. And so what you don't want to do is lay them hard on a backboard. And so if you are going to do that, you would want to pad all around that, because if you lay someone's spine onto a backboard like that, you're going to probably break their back or at least cause extreme pain and cause harm. And rule number one in medicine is do no harm and do no harm. And so this is where you would want to pad that, or just not put them on a backboard. And so, uh, communication can be challenging. We've said this about 100 times. Um, Now, this is something to be aware of. Many calls will occur at a nursing home or a skilled nursing facility or an assisted living. Um, and so, you know, yeah, patients often have an alternate level of consciousness or whatever. These are sick patients if you live in a nursing home. Let me start with that, okay? So everyone in there is sick. And so, or chronically ill, let me put it that way. And so, you're going to notice very quickly, you'll probably even see this on your rotations, your clinicals, that the staff are spread thin. And so it's very common for the patient to, you get there and like the staff will always have an excuse. Oh, I just got here. Oh, this isn't my normal hall. Oh, this isn't my normal patient. Oh, I only work on the weekends. Oh, I only work nights. There's always an excuse, right? I've never had them. It's very rare for they're like, oh, they own the patient, they know what's going on, and they're ready to go. I get it. They're taking care of like 40 chronically ill patients at once. And so it's very difficult for them to do. And so the fact of the matter is that we're on a team here. Check your ego. They've told you what they can tell you. Sometimes it's not good information, and so just take that for what it is. You're going to get shitty information when you go to the nursing home. That's fine. It's not always going to happen like that. Doesn't mean nursing home nurses are not good nurses. It just means that they're stretched thin, or they just truly may not know, or they truly did just get there. And so just be aware of that. It happens. Okay. And so, you could ask what is wrong with the patient that is new or different today. So, a lot of times they'll say, what led us to calling 911 today? And so or what exactly is going on today? If you say what's wrong with the patient, they're going to be like, oh, they'll give you a nursing report. Oh, this is a 85-year-old female with long-standing dementia, type 2 diabetes, Alzheimer's. Stop. What's going on today? And so just be aware of that. Now, older people are not only susceptible to infection, but they tend to be carriers of infection. And so there's this thing called methicillin-resistant Staphylococcus aureus, right? MRSA or MRSA. And so basically this is meaning that this is a common bacteria that is now resistant to this breed of antibiotics. And so they're just resistant to antibiotic treatment. We can still treat them, but you have to use a different type of antibiotic. And so they're just resistant. You're even seeing, what they call like vancomycin resistant enterococci. And so that's happening. So you're seeing all these resistance to antibiotics and these bacterial infections that we used to treat very easily with very simple antibiotics. And so now that that's happening, it creates this whole list of problems. And so, a lot of times you have to give more powerful antibiotics, which are going to create more, adverse effects or higher risk. And we don't like doing that, but it is what it is. And so, we've talked about RSV, the respiratory syncytial virus. And so this is typically in young people, like less than 10 years of age, really at less than 5, where they'll get really sick. But this can also happen in really old people. And in fact, as of recently, there's a vaccine for this. That old and young people can get vaccinated for the RSV virus. Clostridium difficile. So it's a bacteria okay, so this is a bacteria that's normally in your gut. Let me start with that. But what happens if someone takes antibiotics for a long period of time, like 7 days or whatever, 10 days, it can kill all the other bacteria and doesn't kill the Clostridium difficile bacteria in your intestine. So it overgrows. And when this overgrows, it becomes, the patient will be symptomatic. They'll have a very distinct, very, very distinct smelling poop that is usually very slimy, mucousy, yellowish in color with watery diarrhea. It can even be bloody at times. And so the treatment for this, oddly enough, is even more antibiotics to kill all the bacteria. And so you'll see this when patients take clindamycin for an infection. And, you know, at the end of the antibiotics, now they have this watery, slimy, foul smelling diarrhea. And so that's something to be aware of. And so interestingly, C. diff can live in spores. And so spores are like little seeds. So they like it's a bacteria that's within a seed. And so alcohol typically doesn't kill this. And so this is where you need to like soap and water and literally wash it off your hands. And so when you enter the nursing home and they're on what's called contact precautions, typically you'll have to don a gown and a mask and gloves. And that's to make sure you don't get the C. diff bacteria on your skin and on your uniform. And so you don't accidentally transfer this overgrown bacteria to the other patient. And so the bad thing about C. diff is a lot of older patients in nursing homes are incontinent, so they'll end up passing this from patient to patient to patient down the hall. The nursing staff will, the nurse aides and stuff, because everyone's incontinent, so everybody's pooping on themselves, so the staff are cleaning up a bunch of poop all day, unfortunately, and so it's very contagious, is what I'm saying. And so this is one of the few, one of the few bacteria that is not treated well by alcohol-based hand sanitizers, okay? This is why you should wash your hands with warm soap or warm water and soap. SARS-CoV-2, don't have much to add on that. This is COVID-19. Been there, done that, right? It's spread through airborne droplets, loss of smell, taste, flu-like symptoms is how it presents. This can obviously be deadly in old people. We saw a lot of old people die from this during COVID at the beginning of it. Okay. Now, dying patients, more patients are choosing to die at home rather than a hospital. I respect that. That's fine. To each their own. And so when someone's dying, we can provide what's called palliative care. And so this is like care to relieve pain and like discomfort. So it's basically comfort care. And so be understanding, sensitive, and compassionate. I would personally want to die at home if I knew I had to die. And so determine if the family wishes for the patient to go to the hospital or stay at home. Now, granted, this is not, oh, grandma's vomiting blood. Do y'all want to keep her here for palliative care? No, that's not what this means. Typically, they're discharged from the hospital to palliative care, typically. And so advanced directives is retouching on some of the medical ethical stuff that we talked way back when at the beginning of this course. And so an advanced directive is a specific legal paper that directs relatives and caregivers about the kind of medical treatment may be given to patients who cannot speak for themselves. This last part is so important. Patients who cannot speak for themselves. So when is an advanced directive valid? When the patient, like a power of attorney or something like that, it's when the patient can't speak for themselves, okay? And so a do not resuscitate order, a DNR order, gives you permission to not attempt resuscitation for a patient in cardiac arrest. So typically this has to have the patient or a proxy's signature. It's signed by 2 physicians. It's a standardized form in the state of Texas. It looks like this. And so, every hospice patient will have this. But keep in mind, a DNR is not a do not treat. Okay? Cannot stress that enough. A DNR means do not resuscitate. So no intubation, no ventilation, no chest compressions, no cardiac drugs like epinephrine and stuff like that. That doesn't mean no oxygen. You can put an on a breather. You can do a nasal cannula. You can do positions of comfort. This simply means you're not going to do CPR. That is resuscitation. And so just be aware of that. Like I see this all the time where they'll be like, oh, the patient's dying. What do you do? You don't resuscitate. You don't start CPR. Okay. Now, there's another type that is called the POLST, or Physician's Orders of Life-Sustaining Treatment, which gives medical orders in addition to the advanced directives. And so, they might say like, oh, if I go into cardiac arrest, I only want medicine. I don't want chest compressions. Or if I go into cardiac arrest, you can only intubate me. You can't do chest compressions. You can do stuff like that, right? And so that's rare, but it does exist, okay? And so you just honor it. It's a legal document, it's binding. Now they test you on this, and I see students eat it all the time on this. If there's any question regarding the orders or when there are no written orders, we initiate resuscitation. So the family thinks there's a DNR, but they can't find it. Initiate resuscitation. The family is not sure if they have a DNR, or they're not sure if they want to honor initiate resuscitation. So the rule of thumb is you start resuscitation until told not to by like your medical control, or if they produce a valid DNR or something like that. And generally, if you initiate resuscitation, you don't stop until told to by a doctor. Okay? So when in doubt, and what they'll do on these vignettes and test questions is they'll create this very questionable scenario. You're like, I don't know what to do. Well, the answer is to initiate resuscitation. Okay, if you don't know what to do, you initiate resuscitation. So when in doubt, CPR it out. Now, elder abuse and neglect. This is actually more common than what we think, and so this is defined as, know this definition: any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's person, property, or emotional state. Now, interestingly, just like child abuse, this can include acts of commission and acts of omission. So, an act of commission, right, is something that you committed. It means something that you did. An act of omission is meaning something you did not do. So what do you mean? Something you did not do could be neglect. If you omitted the fact that you're supposed to give this patient their medicine, and you're omitting that, you're not doing that, that would be an act of omission. So that could be a form of abuse or neglect. And so an act of commission, if you committed sexual assault, right? Like that's obviously an act of abuse. And so those are both, it's important. You could not do something and still be abuse or neglect, and you could do something it could still be abuse or neglect. So be aware of that. It could be confusing, but there's plenty of examples you can come up with on that. And so, interestingly, elder abuse has been largely hidden from society. I don't think we catch this as often as it's happened. And it's because victims are often hesitant to report the problem. This is their caregiver and that's all they have. And so they're afraid to report their abuse, unfortunately. Very, very sad. And so the abused person may feel traumatized by the situation or be afraid of the abuser that will punish him or her for reporting the abuse, or they think reporting the abuse, it won't get investigated or stopped. And so, interestingly, elder abuse occurs more often in women older than 75 years. And so abusers abusers of older people are sometimes products of child abuse themselves. So you'll see they were abused as a child, and now they're abusing older people as well. Cycle of abuse. It's terrible. And so, especially in terms of neglect, this is where we want to take note of the environment, right? Are the conditions the patient lives in, the soft tissue injuries that cannot be explained by the person's, lifestyle or physical condition. So, why is there bruising all over the thighs and the butt and the back and the lips? They're being abused, doesn't make sense. And so, suspect abuse when answers are concealed or avoided. So, like, where do these come from? And they're like, oh, nothing. Don't worry about that. We're here for the nausea, not the bruises, right? Like they're trying to hide something, like, something like that. Okay. And so when suspect abuse when you are given unbelievable answers, either from the patient or the caregivers, right? Like, oh, why are you all bruised? Oh, well, I always bruise, right? And it's like severe bruising throughout the whole body. And you're like, oh, this doesn't make sense. And so, or the patient will look you in the eye, or the patient's tearful, or the patient, is afraid to answer questions and will only talk to you when the caregiver is absent or something like that. Just be aware of those subtle signs for abuse. When your spidey senses are tingling, let them tingle and be like, oh, there's something wrong. I need to look into this. And so these are information that may be important in assessing abuse includes caregiver apathy about the patient's condition. So apathy means they don't care, right? They have okay, yeah, they have chest pain. Oh, you really need to go to the hospital. They're apathetic, right? Like they don't care, right? They have no sympathy for the patient. Overly defensive reaction by the caregiver, like, okay, well, we need to take you to the hospital. Whoa, we just want you to take the blood pressure, something like that. Like they're very defensive. Caregiver does not allow the patient to answer the question. This is probably the one that's, for me, the easiest giveaway. of when the patient has the ability to answer questions, but they're not, the caregiver is, even when you're directly questioning the patient or trying to tell, okay, well, let me talk directly to the patient, ma'am. Like you're telling the bystander or caregiver, be quiet, and you want to talk to the patient, and they're interfering with that or become defensive with that, that would be a red flag. Repeat visits to the ED or clinic, a history of being accident prone that doesn't make sense, unbelievable or vague explanation of injuries. Really, it's pretty similar for child abuse. And so, information that may be important in assessing abuse includes the psychosomatic complaints. So, the psychosomatic complaints, these are things that you can't see. So, this would be like nausea, fatigue, weakness, stuff like that. Um, Chronic pain without medical explanation, self-destructive behavior like pulling out their hair or, hitting themselves or something like that, refusing to take medication, not eating or sleeping disorders, depression or lack of energy, substance and or sexual abuse history. Those would all be things to know. Okay. And so again, uh, abuse is not just like, oh, they got beat on, they got punched, right? And that could happen, and that's a form of physical abuse. So the forms of physical abuse are assault, neglect or abandonment, dietary, so malnutrition, so they're starving them. I've seen that twice that I can think of. Poor maintenance of the home, poor personal hygiene, sexual assault. Those are all forms of physical abuse. Psychological abuse is benign neglect. So they're just neglecting them. They're just not helping them meet their ADLs and what they need to live. Verbal abuse, treating the patient as an infant, uh, uh, deprivation of sensory stimulation, right? So they're taking away, like, maybe they like to watch TV and they're taking that away, that would be abuse, or something like that. And financial abuse, this is probably the fastest growing form of abuse right now, is financial abuse by scams. And so, people can be embezzled or theft of their valuables or something like that. You'll see this a lot with caregivers too. They'll, steal their jewelry, or, bad caregivers obviously are stealing the client or the patient's jewelry or money, or, tricking them out of their house or whatever. And so, this is an important thing to know. Inflicted bruises are usually found on the buttocks, the lower back, genitals, inner thighs, face, ears, lips, stuff like that. And so these are all places where you would get hit, right? And so, um, just be aware of that. Pressure bruises caused by a human hand may be identified by oval grab marks, pinch marks, or handprints. So you could literally see like a handprint to the face, or where they grabbed the wrist real tight and squeezed it, where they pinched them with their nails or something like that. Human bites are typically inflicted in the upper extremities and cause laceration and infection. That would be obvious. But yeah, I would agree. You typically don't see people getting bit in the lower extremities. That's not by humans. By dogs, yes. By humans, no. And so you could be burnt, cigarette burns, matches, heated metal, just like children, forced immersion into hot liquids, scalding burns, chemical burns, electrical power sources, just like children. And so neglect is a form of abuse, and so you could see neglect like with lack of hygiene, poor dental hygiene. They're not bathing, they're not clean, their clothes are dirty, they're soaked, their bed soaked in urine and feces. It's obviously not fresh. Lack of reasonable amenities in the home. Okay, and so these are all signs of neglect. It's a form of abuse. And so, regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Okay, and so old patients can get STDs, and so an 88-year-old lady that now has gonorrhea, like that's sexual abuse until proven otherwise, right? And, if she's telling you she's not sexually active, that's she may have been raped, and so be aware of that. That does happen. So the geriatric patients with an altered mental status, they may not remember the act of the rape, right? They have such bad dementia, or they're delirious, or both, and they don't remember getting raped. And so this is terrible, but it certainly happens. And so abusers will exploit that fact that they're not going to remember it. And so this is where, testing and the police department would get involved, law enforcement. So many women do not report cases of sexual abuse because of the shame and the pressure to forget. So it's called not regression, repression, where or suppression, but more so repression, where they want to forget it. It's a coping mechanism. All right, that's it. So let's do these questions real quick and end this puppy. And so let's see. The least common cause of death in a patient over 65 years of age is the least common. That's no, it's a leading cause. Leading cause. Oh, this one, drug overdose. It's actually a leading cause of young people right now in the United States because of fentanyl. Fentanyl overdose is killing more people than any other cause. It's surpassed accidental trauma actually in the United States, and so a very sad state of affairs in America with uh, fentanyl being smuggled into our country and killing our youth. There's not in the history of mankind been a greater cause of death of our youth than than fentanyl, than drug overdose. So very, very, very sad that our government and our society is allowing this to happen. So it's D, drug overdose. It's more common in young people. According to the Jim's Diamond, a person's activities of daily living are evaluated during the ADLs. Mm, I don't want to say social assessment is more so like, are people checking out? I'm going to say environmental assessment. I'm going to say environmental assessment. And I got it wrong. Cool. Shout out. I'm off to a great start. Social assessment. So social, the patient's activities, they live in eating, dressing are evaluated. I could have swore that that was in the environmental. Hold up. Okay, I was wrong. Fine. A condition that clouds the lens of the eye is called, it's called a cataract. Okay, and so this is common. If you've ever seen an old dog, you've probably seen this. Cataract. Nystagmus is bouncing of the eyes. Next time your friend is drunk, have him follow your eyes horizontally, and they'll have nystagmus. This is when the eyes bounce. Astigmatism is what I have. It's where you'll see, you have a distortion of the lens of the eye. And so glaucoma is increased intraocular pressure. You are called to a neatly kept residence for an 80-year-old woman who lives by herself. She burned her hand on the stove and experienced a full thickness burn. Yikes. When treating the patient, it is important to note that um, there's a high likelihood that she has been abused. Maybe not. Isolated full thickness burns to the hand are not critical burns. That is false. The patient should probably be placed in assisted living center. No. Slowing of reflexes cause a delayed pain reaction in older people. Yeah, that is true. I would say D. Yes. So this is where they'll grab something hot, and like if you're young and you have intact reflexes, you'll pull away really quick, but they may not pull away quick enough to where maybe if I grab something hot, I get a superficial burn. But an old person that grabs it and doesn't pull away, but for a few seconds, and then they let go, they might get a full thickness burn. The slow onset of progressive disorientation, shortened attention span, and loss of cognitive function is called. Okay, the keyword here is slow onset, so it's going to be dementia. Boom. So watch for words like that. Slow onset equals dementia. They could have literally changed this question and said, like, if they were to wrote fast or acute onset, then it would have been delirium. They're that similar, but it's the time of them and sometimes age that'll make the difference for you. Sentility is just it has to do with getting old and you're going to become more forgetful. So it's kind of like normal aging. A 61-year-old male, or sorry, 71-year-old male presents with a history of hypertension and vascular disease. Presents with tearing abdominal pain. Okay, that's an important phrase. The word tearing, I'll talk about that. His blood pressure is 80 over 60. His heart rate is 120. Respirations are 28. Your assessment reveals that his abdomen is rigid and distended. That is important. Considering his medical history and vital signs, you would be most suspicious of definitely aortic aneurysm. Okay. So remember, that's where the balloon and the aorta will balloon, and so you can tear between the layers, and that literally they will report a tearing pain. But in this case, it's actually torn. Looks like completely because now they're in full-blown decompensated hemorrhagic shock. They're bleeding into their abdomen, and that is causing the abdomen to be rigid and distended because it's filling with blood. Remember, when the abdomen fills with blood, you get peritonitis to where it'll be. You can have what's called board-like rigidity, to where the abdomen becomes very hard and rigid and hot because blood is hot. I picked right, yeah. Okay. Which the following is a physiologic change that occurs during the process of aging? Okay. So you would have an increased elasticity. No, this would decrease. It decreases. A gradual decrease. No, this increases. Blood pressure goes up as we age. A declining kidney function. Yes. 10 to 15% increase in brain weight. No, it decreases. Again, it decreases. Okay. So C, final answer. And this is what I was saying. By the age of 85, a 10% reduction in brain weight occurs. So your brain shrinks by 10% by weight. Which of the following conditions makes the elderly patient prone to fractures from even minor trauma? Osteoporosis. That's thinning of the bone. Who gets it? Old skinny old women. Everyone can get it though, but that's the prototypical patient. Brittle bone disease. Which of the following conditions make the elderly patient prone to fractures from even minor trauma? Oh, sorry. Polypharmacy is a term used to describe a patient who takes multiple medications. Let me make sure these other ones are not it. No, multiple medications. Go ahead. That one was pretty easy. Some of these are just definition based. That's why I always recommend y'all read the vocabulary section and the key summary points at the end of the chapter. They pull so many questions from that. You should know those. Inflicted bruises are commonly found in all the areas except. Yes, they're found in the buttocks. Yes, they're found in the lower back. Yes, they're found in everything. It's the forearms. Now, let me make sure this is right. Yeah. Now, let me tell you this. The forearms can be a sign of defensive bruises, right? And so if someone's trying to defend themselves, they could have bruises to the forearm, specifically this portion of the forearm, right? Which would be the medial portion of the forearms, right? Because you protect yourself like this. So you're going to get it on this arm, the medial, and on this one, the lateral. Okay, so it depends on how you're trying to protect yourself. Wait, no. That'd be lateral on both sides. What am I saying? It's the No, wait, that is medial. Because in the anatomical position, this is medial. Sorry. Medial, and then... Yeah, it's medial on both arms. Sorry. Brain fart. Okay, that's it for this chapter. I appreciate y'all's attention.